Thank you so much for joining us, especially on a rainy night as it gets colder and we're moving into winter. As you know, we host educational sessions for the Coriell Personalized Medicine Collaborative after each result we release. So we're excited that you're joining us to hear more about rheumatoid arthritis. If you have not joined us before, we have sort of a consistent format that we use. We invite a physician expert on the disease. He or she always speaks first. In this case, it's Dr. Feinstein who's joining us. And then I will talk a little bit more specifically about the CPMC results and the genetics of rheumatoid arthritis. So tonight we are delighted to have Dr. Feinstein joining us. He is an assistant professor of medicine at Cooper University Hospital, and he works in the Division of Rheumatology. He's been there for about 6 years, and we're excited to hear what he has to share about rheumatoid arthritis. So thank you.
Good evening. How's everybody? Good. Can you all hear me very well? It's been a long day, so we'll try to get through everything we need to know about rheumatoid arthritis in the next 30 minutes or so. But I have some very interesting pictures to look at if you're not too familiar about rheumatoid. This is always one of the topics of debate as to when we see patients in the office. A lot of patients will come in, do I have rheumatoid, do I have osteoarthritis? And osteoarthritis is the typical arthritis that most people get, that 20 million plus people have in the country. It's the wear and tear arthritis of getting older, and a lot of sports players will get it a little bit earlier in life, but this is the osteoarthritis is that it's kind of a non-inflammatory type of arthritis, and it's associated with aging. Rheumatoid arthritis is a more inflammatory type of arthritis. It's an autoimmune condition, and it can really affect any age group from age 2 through 100. There's a lot of kids who are diagnosed with juvenile rheumatoid arthritis. The difference between non-inflammatory and inflammatory types of arthritis is, a lot of times people will have a little more stiffness in the morning when they wake up. Typically with regular arthritis, they'll have about 10-15 minutes of stiffness, but with rheumatoid or other types of inflammatory arthritides, it can last for 45 minutes or an hour or 2 hours, or we hear all day. And usually inflammatory types of arthritis feel a little bit better the more active you are, whereas regular arthritis feels worse the more active you are. So you can kind of differentiate the two based on history. Also, a lot of times we can differentiate the two based on the location. So patients with regular arthritis, they tend to get it in the most distal aspects of their fingers, whereas rheumatoid will affect more of the knuckle area and the wrists. So there's a few different types of inflammatory arthritides that we deal with, and today we're talking about rheumatoid, but there's also a condition called ankylosing spondylitis, which can lead to this decrease in posture over a length of someone's lifetime. This usually occurs in men of younger ages, around 20s. And there's also psoriatic arthritis, which can present very similarly to both osteoarthritis and rheumatoid arthritis, but obviously to diagnose somebody with that, you have to have a history of psoriasis. But just because you have psoriasis doesn't necessarily mean you're going to develop arthritis associated with that. So there's a few take-home messages I just wanted to bring to your attention regarding rheumatoid arthritis specifically. And that is, over the last 10 to 15 years, the way we treat rheumatoid has really changed dramatically. It used to be that we would treat patients kind of in a slow manner. We would try an oral drug for a few months and then try to switch them to something else. But now we try to be really aggressive. And similar to cancer, a lot of patients get multiple treatments at once to try to knock out the cancer. We do the same thing with rheumatoid. Sometimes we'll add a lot of different treatment options all at the very onset to try to knock out rheumatoid as fast as we can. And the earlier you treat somebody, usually the better the prognosis is. So if someone has rheumatoid arthritis for years and years, and then they finally decide to see a doctor or a rheumatologist, it's a little bit harder sometimes to treat those patients. So we really want to identify these patients very early on. There are also new tools now available to make that diagnosis a little earlier. There's been new criteria that have been established recently There's new modalities such as different lab tests that we didn't have 10 years ago and different imaging modalities that we didn't have just 5 years ago. So this is a typical patient who comes in with hand pain. And you know, when you look at these hands, they don't look too abnormal other than the fact that the picture is a little grainy. But you know, if you look a little more closely here, you'll see a little bit of swelling in these joints. And that's really, when we see a lot of these patients, it's kind of hard to differentiate, do they have regular arthritis or rheumatoid arthritis? And this is where you want to really catch people because you want to prevent them from progressing to the point where now they're getting more swelling. So you see a lot of swelling in here. And then this is a more severe or moderate case of rheumatoid arthritis where now you're starting to see a lot of different changes to the bony structure, a lot of different atrophy of muscle tissue. And a lot of patients develop these nodules that are associated with rheumatoid arthritis. And this is obviously a much more severe case. And to be quite honest, we hardly ever see this anymore. With the new medications that are available on the market, this is more of a rarity than, you know, which is good. But here you can see this kind of deviation of the fingers. The fingers are now moving south. You have the nodules. This wrist is completely deformed. This patient probably cannot do a basic movement such as this. And you know, it makes it very hard to button, put things on, comb their hair. So you know, we're really trying to stay as far away from this as possible and really catch patients when they're more at this stage. This is just another example where the bones have been completely eroded and now the fingers have kind of a floppy look to them and they have very hyperextensible fingers now because they basically have lost their bone. Again, a much more severe case. In rheumatoid, we get these classic findings where you have this kind of swan neck look to the fingers and this what we call a boutonniere deformity. So a lot of patients in the older days, I would say 10, 20, 30 years ago, may have this look, but nowadays we hardly ever see this. So just one brief slide on the pathogenesis of rheumatoid arthritis. I just wanted to make you aware, you know, this being the cartilage layer here, which is kind of like the icing on the cake. It overlaps the bone. And the joint itself, which is right here, is surrounded by a capsule. And what happens is this synovial membrane or capsule begins to get thickened and inflamed. And it causes a lot of vascularity, new blood flow to the area, and eventually starts to erode the cartilage and erode the bone. And this can obviously lead to a lot of deformity. So again, we want to catch patients there and prevent it from getting any further. Now the problem with rheumatoid arthritis is not everybody is the same. Everyone presents differently. There are some people who come in, they have had joint pain and swelling for 6 weeks and it came on suddenly out of the blue. We can't identify any triggers. We can't figure out why it happened. But they'll develop this kind of acute onset, which eventually over time will just go away. There are other people who will have this kind of chronic course where it comes real quick and then goes, and then comes real quick and goes. But then there's these other people who just get this advanced, progressive, severe type of picture, which leads to those deformities I showed you. So if you look at some of the early X-ray findings, this is a joint space which is very well maintained. But over time, you start to see kind of a loss of the space, and the bone starts to get eaten away. And this is what this is showing you, the loss of the joint space and eroded bone. What we know over time is patients can have a lot of inflammation, but it's really, when you look at in terms of disability, it's joint damage, which seems to be very highly correlated with disability. So what we aim to do is improve patients' function right now, but we aim to prevent disability 10 to 15 years from now. But based on that slide I showed you, everyone presents differently and everyone has a different clinical course. So it's very hard to predict who that patient will be when you're first seeing them in the office. So one of the things as physicians we have to determine is who do we think is likely to develop that debilitating disease or that progressive severe type of disease. If we think that we have a patient like that, there's a lot of different DMARDs, what we call them, or disease-modifying anti-rheumatic drugs that we use, which have been around for decades, most of which are oral agents. But the one that's most commonly used is a drug called methotrexate, and I'll get into that a little bit later. But one of the things that we also have to decide is if the patients are not responding to one drug or another, how long do we wait to switch them? Do we add something? How do we decide to use the new drugs versus the old? So based on a lot of older studies, we've now learned that when patients develop rheumatoid arthritis, it doesn't take 10 to 20 years to develop the erosive, severe, bony, destructive changes. It actually occurs right from the get-go in the early stages, usually in the first 2 to 3 years. So the window of opportunity that we like to shoot for is, get them in early and treat them aggressively and treat them as hard as possible to kind of put this into remission as quick as we can, if possible. And obviously the goals are to prevent the functional decline of a lot of these patients, prevent radiographic damage, prevent patients from ending up on disability, and then there's a lot of other comorbidities that are associated with rheumatoid that we want to prevent, such as heart disease or potential cancer. So when you look at an X-ray, this is really a normal hand, and this is the joint space, which is really normal for most patients. You can see the space in between all the 8 wrist bones. So when you get a patient like this, after only 4 to 6 weeks of complaints, you're not going to see any abnormalities on an X-ray, most likely. But you certainly don't want to get the patient when they're coming in like this, where you have no joint space. You have all these areas are cystic areas in the bone, and you can see that the fingers are now kind of curving towards that way, both of these hands. Also, the bone density itself is thinning, like osteoporosis. It leads to potential fracture. So there's been new criteria that's been established really pretty recently. There was old criteria that was back in 1987 that we kind of used to identify patients with rheumatoid, but then we learned that we're actually not identifying the early arthritis patients, which we really are aiming to shoot for. So the new criteria have been established, and I'm not going to get into that detail, but it really helps us to identify those early arthritic patients and allow us to treat them earlier and define who is a definite rheumatoid patient versus those gray zone areas that we have to deal with a lot. In the past, there's been a few blood tests that we've utilized to diagnose patients with rheumatoid. There's something called a rheumatoid factor, which is an antibody test you can check in the blood. This test is not perfect. It gave a lot of false positives in many patients, meaning that they had a positive test, but they didn't really have rheumatoid arthritis. So this test, called the anti-CCP, and CCP stands for cyclic citrullonated peptide. It's not really worth getting into, but the rheumatoid patients have joints that produce an abundance of this peptide. And eventually, antibodies are made against this peptide, and we can measure this in the blood. And this test came out probably over the last 5 to 6 years and is a little bit more specific and helps us to really identify patients with rheumatoid arthritis a little bit better. The interesting thing about this antibody is sometimes it can present earlier than the symptoms. Sometimes we'll see this antibody, but the patients don't have any pain yet. They don't have any swelling. And that's the type of patient we probably need to monitor at least yearly just to make sure that they're not developing any symptoms. But this is a test that usually is something that we would check after the patient's already developed symptoms, but potentially could be used as a prognostic factor. Some other things that we do, X-rays, as I mentioned before, they may not be very good at identifying rheumatoid patients from the early onset. So MRIs are now becoming more standard of care. Something we do at Cooper is we do a lot of musculoskeletal ultrasound, And we look at joints, basically the joints that are involved based on patients' complaints. And this just happens to be a finger. And all this orange signal here is vascularity that is due to inflammation, basically, of the finger. And this is something that we utilize in our office to help diagnose patients at an early onset. So when do we decide to start somebody on a disease-modifying agent? As soon as we know that they have rheumatoid, and that unfortunately is not very easy for some patients. About 25 to 30% of patients may not necessarily have those antibodies that we check for in the blood. So they fall into this gray area, which it makes things a little bit more difficult. But for most patients, their first-line drug is methotrexate, which it's a drug that is also used for chemotherapy, but in much lower doses. For rheumatoid, it has been shown to decrease inflammation and potentially halt the progression of the disease. And then there's some other medications that we use. Hydroxychloroquine is an older medication that was used to treat malaria many decades ago. And like a lot of medications, serendipitously was found to be useful for other conditions, and rheumatoid is one of those. We also use it for lupus. There's a number of different oral medications on the market, as I listed here. What to give someone is sometimes a little bit of a flip of a coin, a little bit of trial and error. It's really based on age of the patient, the severity of the disease at onset, other medical conditions. But it's not always easy to pick the right drug, and in some regards it may be a little bit trial and error. But methotrexate, as I mentioned, is usually the first-line agent. The things that have come out recently over the last 10 to 15 years, which have really revolutionized how we treat rheumatoid, are these new biologic agents, which are monoclonal antibodies for the most part, which I can get into later specifically about that. But I don't know if everyone's seen commercials for Enbrel or Humira on TV or Remicade. No. But these have really changed how we treat rheumatoid. I mean, the oral older medications didn't really do the job so well. And now that we have these newer medications, there are patients who come in very debilitated, and after a few weeks to a couple months have really reclaimed their quality of life, which has really been quite rewarding. There's a number of different medications on the market now, and most of these, unfortunately for a lot of people, are injections. So you have to inject yourself, or they're infusions. So you have to get an IV placed at a center, and they infuse the medication into your bloodstream. I was kind of obliged to put this slide up here because these medications act on different pathways. The whole cascade of inflammation is highly complex. And these are just a few things of a very complex process, but rheumatoid involves different types of cells, T cells and B cells, and these are very integral cells that are involved with inflammation, infections, autoimmune diseases. These TNF inhibitors, or tumor necrosis factor inhibitors that I mentioned, like Enbrel and Humira, they block this pathway and prevent any further inflammation, which will eventually prevent the destruction of cartilage, the destruction of bone. So all these other drugs also that I listed here, not all of them are TNF blockers, but they may block this I'll say enzyme for lack of a better word, but it'll block IL-6, it'll block IL-1, and we have a lot of different drugs now available to block these certain areas to prevent inflammation. And if you have any questions, feel free to ask me. I don't want to lose anybody, but this is really the basic way I can describe it. This is a more complicated slide, of course, but it's just showing that the areas that we block can be at different cell levels. So a lot of different medications will block different signals and different pathways. And that's really all I want to get into about that. But
do you have any way to check to see what the patient needs? You said it's like hit or miss. Is there anything that you do to say, okay, this patient, we see more IL-6 or the TNF?
the question was whether or not there's a way to know if someone needs an IL-6 blocker or something that blocks IL-1 or something that blocks TNF. And unfortunately, for me, as a clinician, there is not. I don't know from a genetic standpoint if that's possible yet, but those medications I listed, they've all come out over the last 5 to 10 years. So some medications we'll try first because they've been around longer, and we have longer data in terms of risk and infection risk and any side effect risks. So I'll choose the medication that I'm more experienced with, usually before I jump on the bandwagon with something that's brand new. And a lot of times we discover that there are side effects after a drug has been out on the market for 4 to 5 years, but those TNF inhibitors that I mentioned, Enbrel and Humira, particularly, they've been around for at least a decade or longer. So the other thing about the answer to that question is it depends on the insurance carrier, unfortunately. What they'll approve, they have their list of what drugs are coming first on their list, and they'll approve certain ones over others first. And that's unfortunately just the nature of the beast today. So TNF inhibitors, they're very potent inhibitors of inflammation. Like I said, they've revolutionized how we treat rheumatoid since 1998. The good thing about these medications compared to the older oral medications is that in the clinical trials that were done, they've actually been shown to halt or at least slow quite dramatically the progression of rheumatoid. So that patient who comes in with a deformed hand is not going to develop those functional disabilities and those x-ray findings that are more of a severe finding. These medications have really been shown to prevent or slow the progression of the disease. And they don't take a year to work. A lot of times they'll work pretty quickly after about, I would say on average, 1 to 3 months, which is much different compared to a lot of the oral medications. The only problem is that they are pretty costly. So the insurances have to cover the cost of a lot of these medications. Otherwise, the main side effect is empty wallet syndrome, which a lot of people don't want. So these are the available tumor necrosis factor inhibitors. Remicade is an infusion that patients get infused at 0, 2, and 6 weeks, and then every 2 months. Enbrel is an injection that patients give to themselves once a week. Humira is an injection people give themselves once every other week. Cimzia and Simponi are injections people give themselves once a month. Now, they are all very similar, but they do have slightly different chemical structures. So choosing one or the other is usually based on the comfort level of the patient, whether or not they are comfortable giving themselves an injection. And basically the experience of the physician. The newer drugs in this list are these two. These three are the ones that were originally approved and been around for a much longer time. So my personal experience is that these three work a little bit better, even though the convenience of giving a once-a-month injection is very appealing. Unfortunately, our patients are coming back saying that the injection doesn't last for the full month. So I'd rather have patients pain-free than 3 weeks of pain-free and then 1 week of pain. So these medications are considered relatively safe in pregnancy. Like any immunosuppressive drug, we have to be careful in terms of any live vaccinations, but a flu shot is acceptable, the pneumonia shot is acceptable. And one of the things that we have to screen for is tuberculosis, which is usually a lung disease, which sometimes patients don't even realize they have. But you need a tuberculosis test to screen because these TNF inhibitors can sometimes activate tuberculosis, which can cause severe infection. I would say about 99% of our patients, that's not an issue. So the thing that comes up all the time is what are the side effects of the medications, and the most common side effect people complain about, particularly the ones that are injecting themselves, are a potential for rash or irritation to the skin or a burning sensation when they inject the medication in the skin. These are other concerns, such as a slightly increased risk of infection. I already mentioned the tuberculosis. There are a few reports of an activation of multiple sclerosis. I have never, knock on wood, seen a case. Patients who may be susceptible to congestive heart failure, or a lot of patients refer to as fluid on the lungs. Sometimes these drugs can precipitate that, but again, if a patient has congestive heart failure already, that's not the patient that we would give these drugs to. Yes?
What does optic neuritis mean?
Well, it's basically inflammation of the optic nerve.
Okay. So it would be like a red eye situation?
Possibly, and pain associated with that, sensitivity to light. So infection risk is a possibility, of course, and upper respiratory tract infections are the most common thing reported, sinusitis or sore throat. Depending on the area of the country you live in, sometimes patients are more susceptible to certain fungal infections, particularly in the Southwest. That's not usually an issue here in New Jersey. And then there's always the issue of these drugs potentially causing a lupus-like flare. Lupus being another autoimmune condition which can cause rashes and joint pain and can affect other organs as far as inflammation. Again, relatively rare, but something we have to keep in mind. These drugs are also approved for psoriasis, and paradoxically can sometimes cause psoriasis. So we're not quite sure why, but that is one of the things that can happen. So methotrexate, I mentioned before, is the standard of care. This is an oral medication that most people will take once a week. So it comes in very tiny, non-horse pill sized tablets, which basically block another pathway of inflammation, similarly to Enbrel and Humira and the other ones that I mentioned. The problem with this medication is it doesn't work for everybody. And I would say in about 30% of patients it's ideal, but 70% of patients may not respond to this drug alone. So we sometimes have to add things or switch it entirely. If you're someone who likes to drink regularly, even a glass of wine, it's a touchy subject because this drug can potentially affect your liver. And one of the main things people get a little excited about is that it can affect the lungs. There's a possibility that it can cause shortness of breath or coughing in about 3% of patients. Again, knock on wood, I've never had a case, but something to be concerned about. I would say the more common side effects of this medication may be GI upset or nausea, diarrhea, abdominal pain. The hepatitis is something that occurs, but it's not usually an issue. So a lot of times we'll monitor the liver function tests to make sure that the enzymes in your liver are not rising, which is indicative of inflammation of your liver. If that happens, you stop the drug and that usually goes away. But the most common side effects are GI, nausea, and upset stomach. So there's so many different trials that have been done on rheumatoid arthritis and so many different treatment pathways and ideas about how to treat patients. There was this one study that I'd just like to share with you that looked at nearly 200 patients who had early rheumatoid. And what they did was they took a combination of a lot of those medications I listed before and compared them to either agent alone. So they would combine methotrexate and sulfasalazine and Plaquenil and compare it to somebody who just took methotrexate. And what they found was that the patients who had the combination of the drugs, they actually did better. So I know more is not always something that people are too fond of doing, but in rheumatoid, hitting it strong and hitting it aggressively is really how we treat patients now. So they did a 2-year trial and they had a 5-year follow-up. And again, just to reiterate, the combination of the drugs seemed to do a little bit better. It also halted any progression on x-rays. And patients went into remission, about 40% of them who had the combination therapy versus 18% who didn't. And then at 11 years, 87% did really well when they looked at the x-rays in terms of preventing progression. Now, what happens when you can't take any of these medications? Well, a lot of times we can fall back on steroids. And as probably a lot of you already know, steroids don't always have the best side effects either. Steroids can lead to osteoporosis, they can worsen your diabetes, they can elevate your blood pressure, your cholesterol, they can make you gain weight, they make people, it's hard to sleep a lot of times when you're on steroids. But in low doses, it may be the only option, and it's also been shown to help prevent progression of rheumatoid. And sometimes we have that occasional patient where this is all they can take, and it's considered relatively acceptable to do that. So I mentioned before that the TNF inhibitors are very costly. Well, if for some reason it's too much money, the insurance doesn't cover it, there are alternatives, and I just kind of listed them here as combinations. Not that this is something you have to memorize, but just to let you know that there are other options. So, what about NSAIDs, which are anti-inflammatory drugs? They're the Motrins, the Aleve, the ibuprofens, Advils. These make people feel better, but they also come with some side effects, and they don't do anything to halt the progression of the disease. So we use them, but we also recommend trying something else along with the Advil. Of course, the risk of the anti-inflammatories is that it can cause irritation to the stomach. If you have any heart disease or history of stroke, it can put you at further risk for increased heart disease. And if you have any kidney disease, it's considered a no-no because it can potentially worsen the kidney disease. So again, just the goals of our rheumatoid treatment, we want to improve patients' function today, but we want to prevent long-term disability. And again, the goal is to put people in remission. So the medications that we have available today are what are really working, and it's something that's is very exciting in rheumatology. It's why a lot of people go into rheumatology now. We can actually help people who have rheumatoid arthritis, as opposed to 20 years ago where there really wasn't that many options. So that's pretty much it. So if you have any questions.
What role does the diet play?
That's a good question, and it comes up quite a bit. Diet, I think, is important in terms of eating healthy. So going to McDonald's every day, probably not the best thing. Eating fried foods, the usual common sense thing. Vegetables, fruits, anything with antioxidants, I think is very important. Anything with anti-inflammatory qualities to the food. Fish oil is something that a lot of people are taking nowadays because it has anti-inflammatory effects. But to be truthful, I've had a lot of patients who have tried the diet thing first before trying any of these medications that I've probably scared you about. But the diet does not tend to work out in the long run. And unfortunately, patients end up coming back needing these medications. Mm-hmm.
I noticed lymphoma kept popping up there.
Mm-hmm.
Why lymphoma? Why cancer? Why is that a possible side effect
of the rheumatoid itself?
Yeah.
Or so why is lymphoma?
There was one on there, I think.
Yeah.
Lymphoma was listed at the bottom as one.
So the question is, what's the link with lymphoma and rheumatoid, and also the link with lymphoma and the treatments? Well, again, a little bit of a loaded question. I mean, when the immune system is hindered in some way, there's also potential for cancer. There's been a lot of distress in regards to the medications being a possible risk factor for lymphoma, but the problem is we know that rheumatoid arthritis itself, left untreated and left with chronic inflammation that's ongoing, is a risk factor for lymphoma. So it's one of those things, is it the chicken or the egg, which came first? And I don't think we really know what is the true cause of lymphoma. Is it the disease itself and the poor autoimmune or the poor immunity that the patient has, or is it the medications that's causing the lymphoma? We do know, though, from other studies that if you treat rheumatoid arthritis, and you get the inflammation under control, that the incidence of lymphoma actually goes down. So, you know, it's hard to answer, but I don't know what the direct cause of lymphoma is. So.
And you don't know like which lymphoma?
No, it varies. It varies. Yeah.
Internal inflammation, like the covering of your lungs, costochondritis, I believe it's called.
Mm-hmm.
Would you expect methotrexate to take care of that inflammation?
Well, costochondritis is inflammation where ribs attach usually to the sternum here. I don't think, well, it's hard to say. That's not something that is really typically common with rheumatoid per se. I think a lot of people get costochondritis who don't have rheumatoid arthritis, and usually anti-inflammatory drugs are what we recommend for that type of condition. If you're referring to inflammation of the lining of the lung, which is a little bit different, that's something that actually occurs a little bit more in lupus patients and not so much rheumatoid arthritis either. You saw those pictures of nodules on the fingers. The nodules can also occur in the lungs as well, and potentially can go away with treatment as well.
But you would have to add another drug to the methotrexate, I would imagine.
Usually that's the case, yeah, because if you have nodules, then it usually is a more severe form of rheumatoid. Yeah. Let me get her first.
What's the next step if your doctor, say your primary care physician gives you the first test, the antibody test that's
Mhm.
not so specific,
Mm.
and that comes back positive, what should be done next?
Okay, so the question is, if you have seen your doctor and you've had the antibody test, it comes back positive.
Mm-hmm.
I assume you were seeing the doctor because you had pain and that's why they ordered the test?
No, the doctor ordered the test because she knew the results of the study.
I see.
And also there was some pain, but I don't know if it's osteoarthritis or rheumatoid arthritis.
Right, so the test was ordered because of the results of a study, you said. Well, that is something where if you don't diagnose somebody with rheumatoid based on an antibody test alone. So you need to get a good evaluation from a history standpoint as far as joint pain symptoms, joint swelling, morning stiffness, activity, when did it start, how long has it been going on, and then try to, with that and the physical exam, link those findings to the antibody. I have to say a lot of patients will have a mildly positive rheumatoid test, but it doesn't mean they have rheumatoid arthritis. These antibodies are not 100% specific. So
Even with that new test, that anti-CCP test?
the CCP is a little more specific, so if you have both the rheumatoid factor and the CCP antibody, it gives you a higher probability of having rheumatoid arthritis. But still, I'd be reluctant to diagnose somebody just based on a lab test. You want to always link history and physical exam with the blood work. So if your primary care doctor is having a hard time differentiating that and determining whether or not you have regular arthritis versus rheumatoid, then you would see a rheumatologist.
Because you can have both.
You could have both, yeah.
Can you get arthritis in just one joint of your hand, or does it tend to spread to the entire hand, all the joints of the hand?
The question is, can you get arthritis in one joint, and does it spread to the rest of the hand as well? You can get arthritis in one joint, yes. And a lot of patients with regular osteoarthritis may have it only in one finger. That is one good point that you raise, actually, is that rheumatoid arthritis tends to be symmetric in most cases. So if you have inflammation from rheumatoid in the left hand, usually it's in the right hand as well. And again, it's the geography of where the joints are. So if the inflammation is here, most likely it's not regular arthritis. But if it's at the top of your fingers, that's more likely to be regular arthritis.
It's like a nodule.
Exactly.
Just the very last joint.
Yeah.
And sometimes it can hurt like the dickens.
That's
not rheumatoid.
That's usually indicative of osteoarthritis. People get nodules at the top of their fingers here. It's usually osteoarthritis.
But your back, is that more osteoarthritis?
Yeah.
Rather than
For the back is one thing, particularly the low back, that rheumatoid will spare. So rheumatoid arthritis can affect the higher portions of your neck, the shoulders, the elbows, the wrists, certain joints in your fingers, hips, knees, ankles, feet. But the low back is usually from regular arthritis.
Do either hot or cold compresses help ease the pain of arthritis?
Well, if you have acute inflammation that's ongoing, usually ice helps a lot of patients. But if it's chronic and it's been going on for a long time, months to years, it's really dealer's choice. So whatever makes you feel better.
It's not making it worse.
No.
You have somebody, you try methotrexate and methylprednisone and Remicade and they don't respond. What would your next step be?
So if somebody was on methotrexate, Remicade, and prednisone and they did not respond, what would be the next choice? Great question. It's, again, another loaded question, but I think it would depend on your history and the extent of your disease, how progressive it is. We may consider switching you to a different TNF inhibitor, Remicade being a TNF inhibitor. We may want to try Embro or Humira, or switch you to a totally different class of drug altogether. You know, some of the newer drugs that are now available. I think they also have commercials now for Orencia, if you've seen those. This acts on a totally different pathway. So, you know, you can treat and try to knock out rheumatoid from a different approach. So if you've already tried that, you've tried it for an adequate period of time, maybe 3 months or so, you know, we may want to consider changing what we're trying to block. So we may try a totally different infusion or totally different injection.
So my name is Erynn Gordon. I'm the Director of Genetic Counseling for the Coriell Personalized Medicine Collaborative. And I just want to provide a little bit of information about interpreting your CPMC results and some of the genetic versus environmental contributions, implications for family members, and of course some of the limitations of the CPMC testing. So hopefully this picture is familiar to all of you. It comes up on all of your disease-related reports, and we start, when we talk about any of the complex conditions in educational sessions like this, we always start with this slide because this is one of the most important things we can tell you. So the diseases that are included in the Coriell Personalized Medicine Collaborative are not solely caused by your genes, right? They're considered complex diseases, and they're caused by the interaction of multiple different genes and the environment. So none of the information that we can give you through the CPMC is diagnostic, right? Because we don't know everything about you, and we're also not looking at every gene under the sun. So this image gives you some sense of the contribution of your genes versus the environment to each individual condition. So you'll see this in every report. You'll see that the balance changes. In some cases, for example, your age-related macular degeneration result, the genetics bucket is heavier. It's about 80% genetic and only 20% non-genetic or environmental. Some other things like coronary artery disease, it's closer to 50-50. So this information just gives you a little bit of perspective on how much your genes contribute versus how much the environment contributes. When we zoom in on this, one thing that's really important to understand is that there are multiple genes filling this bucket. So we are telling you about one particular gene, but there are multiple different genetic variants that influence the genetic component of not only this condition, rheumatoid arthritis, but of each condition. So although we're saying this is 53% genetic, we're not telling you about the whole 53%. We don't understand the whole 53%. The scientific community has not synthesized all of that information yet to say, okay, this gene accounts for 10% of that 53, this one accounts for 2% of the 53. So we really only have an early insight into this genetic bucket. In this particular case, we're telling you about a gene in the TNF pathway, which is one of the genes, one of the types of treatments that Dr. Feinstein talked about. So I'll say here, someone had asked about the relationship between genetics and treatment selection. And at this point, based on what we know about the genetics of rheumatoid arthritis, that's not something that is routinely done. Whether or not that's something that healthcare providers will be able to do in the future, that's a possibility. We don't know. The problem is that people who have rheumatoid arthritis probably have genetic changes in lots of different pathways. So to say, well, if you have a genetic variant in the TNF pathway, you should be given this drug, but not these other ones. Well, you probably have variants in lots of different pathways. So it might be hit or miss. Decisions may be made down the road based on the number of variants in each individual pathway. So maybe if you have 5 changes in the TNF pathway, but only 2 changes in the PTP pathway, then we would give you a drug related to TNF and not PTP. But we're just not at the point now in medical treatment where we can incorporate all of that information and make treatment decisions based on that. We know that multiple genes play a role, but the relative contribution of each one is still unknown. So we can't say this accounts for 5%, this accounts for 10%, this is 20%. We can't tell you how strong each one is, and we might, once we understand that down the road, that information then might be able to be used in treatment decisions. So in this case, we've looked at one particular variant. Again, it's in the TNF pathway. In all of your CPMC results, we'll give you what's called an RS number. This is the scientific reference number. Sounds like we have a little background music. Assuming it's someone's ring, we figured it would end at some point. So we've labeled this variant 1 because we hope to provide you with additional genetic information down the line, which we would name 2, 3, and 4. But if somebody were to look on the internet for more information, this is the scientific reference number, and so we provide that as well. In our standard format, we always tell you what gene this is in or near. This is the chromosomal region is basically the genetic address for the gene. We all have, if you remember back to high school biology, we all have 23 pairs of chromosomes. The first 22 are numbered, and so this is telling you this is on the, can't see from over here, but I think it says the 6th chromosome. And then in every case, there's the normal and expected sequence. You either have, at the particular spot we're looking at, an A, T, G, or C. In this case, we expect most people to have a G. And in some people, we see a change to an A. And that change to an A is associated with an increased risk of rheumatoid arthritis. This is showing you how common that is. So in about 4% of people, 4 in 100, we would see 2 copies of the A variant, meaning that those people have a greater risk for rheumatoid arthritis. In 35% of people, we see 1 copy of the A, 1 copy of the G. So those people have a slightly increased risk over the general population. And then in the majority of people, 61%, we see 2 copies of the G. That means they have what would be expected, sort of the normal version of this particular spot in the genome. As always, we do try to provide you with family history and information on a non-genetic variant. Again, these are not solely genetic conditions. If we were giving you results for something like cystic fibrosis, that would be different. Cystic fibrosis is an example of a disease where it's caused by a single gene. If you have a mutation in that gene, you will have the disease. That's something called a single gene disorder. One cause, one effect. And the diseases we're talking about here are different than that. They're caused by multiple genes working together in combination with the environment in order to cause a disease. So we want to highlight some of these other risk factors. In this case, we've provided information on family history, smoking, and this particular genetic variant. I think it's important to note that it's not always the genetic information that's the most powerful here. So in this particular case, knowing that you have a family history and having a family history actually has a much stronger impact on your risk than any one particular genetic variant. In this case, this genetic variant, if you have one copy of the risk variant, you're about 20% more likely to develop rheumatoid arthritis than somebody who does not have this particular variant. And if you have two copies, you're about 1.6 times or 60% more likely to develop rheumatoid arthritis than someone who doesn't have this variant. When we think about family history, in contrast, if you have one parent with rheumatoid arthritis, you're 3 times as likely. That's a lot more times. If you have multiple first-degree relatives with rheumatoid arthritis, you're about 9 times more likely to develop rheumatoid arthritis yourself than somebody else. So for those of you in the room who might have rheumatoid arthritis, you can think about this in relation to your children. For example, if you yourself have rheumatoid arthritis, and maybe you're the only one in the family, your children would have about 3 times the risk of developing rheumatoid arthritis as somebody who did not have a parent with rheumatoid arthritis, someone without a family history. If you have rheumatoid arthritis and you're one of multiple people in the family, so maybe you have rheumatoid arthritis and you already have one child with rheumatoid arthritis, then another child of yours would have about 9 times the risk. So a significant increase. We see this sort of clustering in families. If you also remember back to your results for lupus, which we released maybe a year ago, maybe a little bit more, the risk for lupus is also influenced by having a family history of basically any autoimmune disease. So if you yourself have rheumatoid arthritis, that increases the risk that your children could develop lupus as well. And if you're interested in more in that, feel free to look back at your results and contact myself or our other genetic counselor, and we'd be happy to talk you through that. Finally, as a small glimpse into the environmental component of rheumatoid arthritis, we do provide a risk related to smoking. So people who are currently smokers have about twice the risk of developing rheumatoid arthritis as somebody who's not a smoker. The nice thing, the reason that we try to highlight these non-genetic risk factors is this is really something you can do something about. So for all of our participants out there who are smokers, our hope is that you see this and say, okay, well, I can't change my genes. They are what they are. I got them at birth. But I can stop smoking, and if I stop smoking, that can reduce my risk. Many of the questions that we get from participants relates to the implications for family members and how can I translate this information so that it's useful for my children or other members of my family. So this is just one example. The first thing is you can only predict what genetic result your children will have if both you and your spouse are in the study, or you and the parent of your child, the other parent of your child. Otherwise, we sort of know half the information. So for example, in this case, if we only knew about this woman, right, if we didn't have this information because only the woman was a participant, what we could say is that there's a 50% chance that each of her children will inherit this risk copy. Because we all have 2 copies of every gene in our body. We got one from mom and one from dad. And when you pass your genetic information to your children, you can only pass half of it, right? If we passed everything we had and our partner passed everything they had, our kids have way too much genetic information. That's not a good thing. So we give half of ourselves, our partner gives the other half. So with each children, it's random which one you're going to give. So half the time this woman is going to pass on the G, which is the normal version at this particular spot, and half the time she's going to pass this risk variant that's associated with rheumatoid arthritis. If we know if both parents are involved in the study, then we can say, okay, well we can think through a little bit more what the risk is for each of the children. So we know that about 25% of the time, each parent is going to pass the G, the quote-unquote normal copy, the one that is not associated with rheumatoid arthritis. And the child is going to have 2 copies of the G. About 50% of the time, one parent's going to pass the A and one parent is going to pass the G, and the child will have an increased risk, but only that moderate level, that midway point, because they're going to have one normal copy and one increased risk copy. And then 25% of the time, each parent is going to pass the A, the risk copy, and the child will have the stronger increased risk of rheumatoid arthritis. So there's a possibility with almost every result, we can estimate what the likelihood is for different children, but we can't know that for sure without testing the kids. If both parents have the same thing, so if this woman was GG and this man was GG, we can say children did not inherit this risk factor, right? Because if the parents don't have it, the kids can't have it. It doesn't magically appear from one generation to the next. If both of these parents were AA, so if she was AA and he was AA, we can say the kids are all AA, because you can only give what you have. Your children can only receive what you have. New things don't come up between generations. So just some insight into what the implications are for the next generation. When you look at your own result, you can say, okay, my child either received this one or this one. So if you have 2 copies of the non-risk, the normal version, that's what your kids got from you. If you have 2 copies of the risk version, your children got at least 1 copy of the risk version from you. And then if you have 1 of each, this would be how they're divided. Just a few limitations to consider. CPMC results are not diagnostic, so we are never going to be able to look at your genes and say, you have rheumatoid arthritis, right? Because there is this strong environmental component, so a genetic test will not be able to diagnose you. We know there are other genetic factors that influence the risk of rheumatoid arthritis that are not included in this report. We do hope to include them down the road as our oversight board reviews them and tells us that we can. Your age, your family history, your lifestyle, all have an impact on your risk for not only rheumatoid arthritis, but the other conditions that we tell you about through this study. We do provide relative risk based on groups of people that are similar to you. So we'll tell you if we have data on the relative risk, so the impact of smoking in a Caucasian population, that's the information we're going to tell you about. If you're African American and we have that data on someone in an African American population, we'll give you that data. So we do try to make it as personalized as possible. You'll notice that we don't add everything up and give you one single risk, and that's because scientists have not quite figured out yet how to add these things together. So think about, you get your genes from your parents and you get your family history from your parents, right? So there's a clear overlap there, and we can't say, okay, this number, here's a 20% risk and here's a 5% risk, let's add them because they overlap. We can't say you multiply them. We can't say cut this one in half and then add a portion of that. Scientists are really still trying to figure out how to mesh these numbers together to give people a more comprehensive risk. So at this point, we're still continuing to give you things one risk component at a time so that you can think about each of the factors that might influence your total risk. We do provide risk for non-genetic factors based on what you told us. So if you receive a result saying you're a smoker, we're telling you that because you told us at some point that you're a smoker. If it's incorrect, let us know and we can update that. We will also be sending you probably sometime in early 2012, we'll be asking you to update your medical history questionnaire. So if things about your medical history have changed, you can provide updates then. We always try to offer seminars like these. You can also read some information on our website about rheumatoid arthritis. You can call and make an appointment to talk with either myself or our other genetic counselor, Tara. If you're a little phone shy, you can email us questions, and we try and answer questions as comprehensively as possible by email. And finally, a couple of last things to highlight. We do have some additional diseases that we are releasing results for in the future: colon cancer, inflammatory bowel disease, which will include information on both Crohn's disease and ulcerative colitis. And some of you may have seen our advertisements for an optional study related to obesity. If you're interested, I can tell you more about that. Basically, everyone will get obesity results eventually. Right now, you can get them early by participating in an optional research study that involves a couple of extra questionnaires. Just a reminder, the real purpose of this study is to figure out what the utility of personalized medicine information is. What do people do with this, and is it useful? So we do send you questionnaires about every result that we release. I would strongly encourage you to fill those out. That is extremely useful to us. They take about 5 minutes each. And if you complete it, you are entered into a drawing to win a $25 gift card. So please take the time to do that. And thank you for your attention and your participation.